When we think about neonatal infections, understanding how pathogens reach the baby helps us predict both the clinical presentation and appropriate interventions. Vertical transmission occurs when infection passes from mother to baby. Transplacental transmission happens during pregnancy when pathogens cross the placental barrier. Think torch infections like CMV or toxoplasmosis. These babies often show growth restriction or congenital anomalies because the infection affected development. Ascending transmission occurs when bacteria travel up through the cervix and membranes, typically after prolonged rupture of membranes. Group B strep is the classic example here. The longer those membranes have been ruptured, especially beyond 18 hours, the higher the risk for ascending infection. Intrapartum transmission happens during delivery as the baby passes through the birth canal. Herpes simplex virus is particularly concerning here. Maternal lesions during delivery create significant risk for devastating neonatal infection. Horizontal transmission occurs after birth. Postnatal contact includes family members or healthcare workers who inadvertently transmit pathogens. Nosocomial infections develop in the hospital environment. Central lines, ventilators, and frequent procedures create multiple opportunities for bacterial invasion. Certain viruses can transmit through breast milk, though this is relatively uncommon. CMV transmission through breast milk is well documented, particularly concerning for preterm infants. The timing of infection acquisition directly correlates with disease severity. Earlier exposure typically means more severe systemic disease because immature immune systems cannot mount effective responses. Late onset infections often present more subtly but can still cause significant morbidity. Certain pathogens have evolved mechanisms that allow them to breach the placental barrier, creating congenital infections with distinct clinical patterns we need to recognize. Syphilis crosses easily due to Treponema pallidum's small spirochete structure and ability to invade tissues. Congenital syphilis presents with hepatosplenomegaly, skin lesions, and that characteristic snuffles, the persistent nasal discharge that should immediately raise suspicion. Toxoplasma gondii survives intracellularly within maternal cells, essentially hitchhiking across the placenta. The classic triad includes chorioretinitis, hydrocephalus, and intracranial calcifications, though most infected newborns appear normal initially. Rubella virus causes devastating effects when maternal infection occurs in the first trimester. The constellation of cataracts, cardiac defects, and sensorineural hearing loss defines congenital rubella syndrome. CMV represents our most common congenital viral infection. While 90% of infected babies appear normal at birth, those with symptomatic disease show microcephaly, petechial rash, and hepatosplenomegaly. The key concern is later hearing loss, even in asymptomatic infants. Parvovirus B19 targets fetal red blood cell precursors, causing severe anemia and hydrops fetalis. The timing matters. Second trimester infections carry the highest risk for fetal complications. Listeria monocytogenes thrives in cold environments and crosses through infected maternal cells. Early onset listeriosis presents as sepsis with that distinctive granulomatous rash called granulomatosis infantiseptica. HIV crosses through cell-associated transmission, with higher viral loads increasing transmission risk. Most transmission actually occurs during delivery rather than in utero. These organisms succeed because they're either small enough to slip through placental pores, survive within maternal cells, or establish sustained maternal bloodstream infection that overwhelms placental defenses. The placenta functions as a sophisticated biological filter, protecting the developing fetus while allowing essential nutrient exchange. Understanding how this barrier works and fails explains why certain infections reach the baby while others don't. The syncytiotrophoblasts forms the primary defensive layer. This multinucleated cellular barrier creates tight junctions that physically block most pathogens from crossing into fetal circulation. Think of it as the placenta's frontline defense system. Hofbauer cells act as the placental immune surveillance team. These specialized macrophages patrol the villus tissue, engulfing pathogens that manage to penetrate the initial barrier. They release antimicrobial compounds and coordinate local immune responses to contain infections before they spread. The placenta also produces antimicrobial peptides, natural antibiotics that create a hostile environment for invading organisms. These peptides work alongside maternal antibodies that cross the placenta to provide passive immunity. However, this protective system can break down. Inflammation disrupts those critical tight junctions between syncytiotrophoblasts cells, creating gaps that allow pathogens to squeeze through. Maternal infections like chorioamnionitis trigger inflammatory cascades that essentially open the floodgates. Some clever pathogens actively invade rather than waiting for opportunities. Listeria, for example, uses specific proteins to force entry into placental cells, while CMV hijacks cellular machinery to facilitate its own transport. Pregnancy naturally suppresses maternal immune function to prevent rejection of the fetus. This immunosuppression, while necessary, also reduces the effectiveness of placental defenses against certain pathogens. First trimester infections pose the greatest risk because organogenesis occurs during this critical window. When pathogens cross early in development, they disrupt fundamental cellular processes, leading to structural abnormalities and growth restriction that persist throughout pregnancy. Ascending infections represent a critical pathway where vaginal and cervical bacteria travel upward through the reproductive tract, crossing intact or ruptured membranes to reach the amniotic fluid and fetus. The 18-hour mark for membrane rupture represents a crucial clinical threshold. Once membranes rupture, the protective barrier disappears, creating a direct pathway for bacteria to ascend from the vagina into the uterine cavity. Each hour beyond 18 hours significantly increases infection risk, which is why we're aggressive about delivery timing or antibiotic prophylaxis. Cervical insufficiency creates another vulnerability. When the cervix begins opening prematurely, it allows bacteria to migrate upward even with intact membranes. These patients often present with subtle signs of preterm labor that we need to recognize quickly. Multiple vaginal examinations during labor mechanically introduce bacteria deeper into the reproductive tract. Each exam potentially pushes vaginal flora closer to the cervix and beyond. This is why we limit examinations to essential assessments and maintain strict sterile technique. Internal fetal monitoring devices create direct conduits for bacterial invasion. Fetal scalp electrodes and intrauterine pressure catheters breach the amniotic cavity, providing bacteria with a pathway that bypasses natural barriers entirely. Group B streptococcus and E. coli dominate early-onset sepsis because they colonize the maternal genital tract and ascend readily. Anaerobic bacteria thrive in the oxygen-poor environment of the amniotic cavity once they gain access. Ureaplasma and mycoplasma are particularly concerning because they're small enough to cross even microscopic membrane defects and often cause chronic, low-grade infections. This ascending pathway leads directly to chorioamnionitis, infection of the fetal membranes and amniotic fluid. Maternal fever, uterine tenderness, and foul-smelling amniotic fluid signal established intraamniotic infection that puts both mother and baby at significant risk. Intrapartum transmission occurs during the birthing process as the baby travels through the birth canal, encountering maternal genital tract flora and any pathogens present in vaginal secretions. Group B, Streptococcus represents our most concerning intrapartum pathogen. GBS colonizes the vaginal tract in about 25% of pregnant women, typically without symptoms. When babies encounter GBS during delivery, they can develop devastating early-onset sepsis within the first few days of life. This is why we screen all pregnant women at 35 to 37 weeks and provide intrapartum antibiotic prophylaxis when indicated. Herpes simplex virus creates a particularly high-stakes scenario. Active maternal lesions during delivery can transmit HSV to the baby, leading to devastating disseminated disease, encephalitis, or localized skin and eye involvement. Even asymptomatic viral shedding poses risk, which is why cesarean delivery is recommended for women with active lesions at the time of labor. Gonorrhea and chlamydia cause conjunctivitis and pneumonia in exposed newborns. The classic gonococcal conjunctivitis presents with purulent discharge within the first few days of life. Chlamydial infection often manifests later as a distinctive staccato cough and pneumonia at several weeks of age. HIV transmission during delivery accounts for most mother-to-child transmission. Higher maternal viral loads dramatically increase transmission risk, which is why antiretroviral therapy and sometimes cesarean delivery are used to minimize exposure. Similarly, hepatitis B can transmit during delivery, making immediate immunization and hepatitis B immune globulin critical for exposed infants. Even candida can cause problems, leading to oral thrush or diaper dermatitis in the newborn period. Prolonged labor increases exposure time to these pathogens. Instrumentation like forceps or vacuum extraction can cause maternal tissue trauma, increasing viral shedding and bacterial load. For HIV specifically, higher maternal viral loads directly correlate with transmission risk. Nosocomial infections represent one of our greatest challenges in the NICU, where vulnerable infants face multiple risks from the very devices and environment designed to save their lives. Central lines provide essential vascular access, but create direct pathways into the bloodstream. Central line-associated bloodstream infections develop when bacteria colonize the catheter, typically at insertion sites or hub connections. Coagulase-negative staph dominates these infections in neonates, often presenting subtly with temperature instability or feeding intolerance rather than obvious sepsis signs. Ventilators support breathing, but create ventilator-associated pneumonia risks. The endotracheal tube bypasses natural upper airway defenses, allowing bacteria to reach lower respiratory tract directly. Secretions pool above the cuff, and each suction procedure can introduce new organisms. Gram-negative bacteria like Klebsiella and Pseudomonas frequently cause VIAP in this population. Even urinary catheters, though less commonly used in neonates, provide direct access to typically sterile urinary tract spaces when necessary for monitoring or drainage. Environmental sources create unexpected threats. Humidified isolates provide warm, moist environments where Pseudomonas thrives. These organisms multiply in water reservoirs and humidification systems, then aerosolize directly onto vulnerable infants. Water sources throughout the unit can harbor Legionella, particularly in older plumbing systems or poorly maintained equipment. Equipment contamination occurs when cleaning protocols fail or when items move between patients without adequate disinfection. Stethoscopes, blood pressure cuffs, and monitoring devices all carry potential for cross-contamination. Healthcare worker hands remain the #1 transmission source. Despite rigorous hand hygiene protocols, hands pick up organisms from one patient and transfer them to the next. This is why alcohol-based hand sanitizer dispensers are positioned everywhere and why we emphasize hand hygiene before and after every patient contact. Proper technique and timing make the difference between protecting patients and inadvertently causing harm. Neonatal immunity operates through 3 distinct but interconnected systems that determine how well babies fight off infections during their most vulnerable period. Innate immunity serves as the body's immediate response system. This includes physical barriers like skin and mucous membranes, along with cellular defenders like neutrophils and macrophages that attack any foreign invader without specificity. In neonates, this system functions but at reduced capacity. Neutrophil counts are lower, and their ability to migrate to infection sites is impaired. The complement system, which normally helps destroy bacteria, shows decreased activity in newborns. Adaptive immunity provides the sophisticated, targeted responses we rely on for long-term protection. This system creates specific antibodies against particular pathogens and develops immunologic memory for faster future responses. However, adaptive immunity requires time and exposure to develop fully. Neonates essentially start with a blank slate. Their B and T lymphocytes are present but naive, having never encountered most pathogens. Passive immunity bridges this gap through maternal antibodies transferred across the placenta during pregnancy. Immunoglobulin G antibodies cross the placental barrier most efficiently, particularly during the 3rd trimester. This explains why premature infants have fewer protective antibodies. They missed crucial weeks of maternal antibody transfer. These maternal antibodies provide protection against common pathogens the mother has encountered, including respiratory syncytial virus, pertussis, and influenza. However, this protection is temporary, typically waning by 4 to 6 months of age, as maternal antibodies are metabolized and cleared. The clinical reality is that neonates exist in an immunologic window of vulnerability. Their innate systems are immature, their adaptive immunity is just beginning to develop, and their passive protection depends entirely on what antibodies their mothers could provide. This combination explains why newborns, especially those born prematurely, face such high infection risks and why early recognition of sepsis signs is absolutely critical. Neonatal innate immunity represents the baby's first line of defense, but these systems are significantly compromised compared to older children and adults, creating substantial vulnerability to infection. Physical barriers that normally exclude pathogens are remarkably fragile in newborns. Neonatal skin lacks the thick stratum corneum that provides effective protection in adults. In preterm infants, this barrier is even more compromised. Their skin may be so thin it's nearly translucent, allowing bacteria to penetrate easily. Every heel stick, IV insertion, or tape removal creates potential entry points for pathogens. Mucous membranes lining the respiratory and gastrointestinal tracts are immature and produce less protective mucus. The nasal passages, normally efficient at filtering particles and pathogens, function poorly in newborns. This explains why respiratory infections spread so rapidly in this population. Chemical barriers show significant deficiencies. Gastric acid production is minimal in newborns, with stomach pH often remaining neutral for days. This creates an ideal environment for bacterial overgrowth and allows ingested pathogens to survive passage through the digestive tract. Adults rely on stomach acid to kill most bacteria we swallow. Neonates lack this protection. Antimicrobial peptides, natural antibiotics produced by various tissues, are produced in much lower quantities. These peptides normally help control bacterial colonization on skin and mucosal surfaces. The cellular components of innate immunity also function suboptimally. Neutrophils, our primary bacterial fighters, are present but demonstrate poor chemotaxis. They struggle to migrate efficiently to sites of infection. Their ability to engulf and destroy bacteria is also impaired. Macrophages show immature function, with reduced capacity to process and present antigens. Natural killer cells, which normally destroy virus-infected cells, have significantly reduced cytotoxicity in neonates. This combination of barrier defects and cellular dysfunction explains why neonates develop infections so readily and why seemingly minor breaches in care can lead to devastating consequences. Neutrophils serve as our primary bacterial defense force, but in neonates, both the quantity and quality of these cells are significantly compromised, creating a perfect storm for overwhelming infection. The quantitative problems start with storage. Adults maintain robust neutrophil reserves in the bone marrow. Think of it as a military depot ready to deploy troops when needed. Neonates have only 20% of this adult storage capacity. When infection strikes, they quickly exhaust their limited neutrophil supply, leaving them defenseless against continued bacterial invasion. This rapid depletion explains why we see neutropenia develop so quickly during neonatal sepsis. Unlike adults who can mobilize massive numbers of fresh neutrophils, babies simply run out. The bone marrow cannot keep pace with demand, especially in preterm infants whose hematopoietic systems are even more immature. The qualitative defects are equally problematic. Chemotaxis, the ability of neutrophils to migrate towards sites of infection, is severely impaired. Think of neutrophils as emergency responders who cannot effectively follow the chemical signals calling for help. They may be present in the bloodstream, but struggle to reach the actual site of bacterial invasion. Rolling and adhesion represent the mechanisms neutrophils use to exit blood vessels and enter infected tissues. Neonatal neutrophils demonstrate poor adhesive interactions with blood vessel walls, essentially sliding past infection sites without stopping to help. Even when neutrophils do reach the infection site, their phagocytic function is compromised. They engulf bacteria less efficiently than adult neutrophils. More concerning, their intracellular killing mechanisms are defective. They may capture bacteria, but fail to destroy them effectively. These combined deficiencies result in poor bacterial clearance, explaining why neonatal infections progress so rapidly and why early antibiotic intervention is critical. The neutrophil dysfunction also explains why we see such subtle clinical signs initially. The inflammatory response that creates obvious symptoms simply cannot mount effectively. Adaptive immunity represents the sophisticated, learned immune responses that provide specific, long-lasting protection against pathogens. However, neonates start life with essentially naive adaptive immune systems that must develop through exposure and time. T-cell dysfunction creates significant vulnerabilities in newborns. The neonatal immune system demonstrates a pronounced Th2 skew, meaning it favors antibody-mediated responses over the cell-mediated immunity that effectively fights intracellular pathogens, like viruses and certain bacteria. This explains why newborns struggle particularly with viral infections, and why conditions like respiratory syncytial virus can cause such devastating disease. Cell-mediated immunity, which relies on cytotoxic T cells to destroy infected cells directly, functions poorly in neonates. These cells exist but lack the activation and effector functions seen in mature immune systems. When viruses infect neonatal cells, the T cell response often cannot eliminate the infection effectively, allowing viral replication to continue unchecked. Memory formation represents another critical deficiency. Adult immune systems create immunologic memory after pathogen exposure, enabling rapid, robust responses during future encounters. Neonatal T cells struggle to form these memory populations, meaning each infection encounter feels like the first exposure, without the benefit of prior learning. B cell function shows equally concerning limitations. While neonates can produce some antibodies, their production is limited and predominantly consists of immunoglobulin M, the class switching process that generates more specific and effective antibody types, like immunoglobulin G, occurs poorly in newborns. Perhaps most importantly, neonatal B cells respond very poorly to polysaccharide antigens. Many bacterial capsules consist of polysaccharides, making this deficiency particularly problematic for fighting encapsulated bacteria like Streptococcus pneumoniae and Haemophilus influenzae. This adaptive immunity develops gradually over months to years, explaining why infants remain vulnerable to infections well beyond the neonatal period and why vaccination schedules are carefully timed to provide protection as maternal antibodies wane and before adaptive immunity fully matures. Passive immunity represents the crucial bridge that protects neonates during their most vulnerable period, transferring maternal protection directly to the baby through antibodies that cross the placental barrier. The transfer of immunoglobulin G begins surprisingly early in pregnancy, starting around 16 to 20 weeks gestation. This process relies on a specialized transport system using the neonatal Fc receptor, which actively pumps maternal antibodies across the placental barrier. This isn't passive diffusion, it's an energy-requiring process that selectively moves protective antibodies to the fetus. The timing of this transfer creates critical implications for preterm infants. Maximum antibody transfer occurs after 32 weeks gestation, meaning babies born before this threshold receive significantly fewer protective antibodies. A baby born at 28 weeks has far less passive protection than one born at 38 weeks, which partially explains their increased infection susceptibility. The antibodies that successfully cross provide protection against specific pathogens the mother has encountered or been vaccinated against. Group B, Streptococcus protection depends entirely on maternal antibody levels, which is why maternal GBS colonization status matters less than whether the mother has protective antibodies. Tetanus and diphtheria protection comes from maternal vaccination history, highlighting why maternal Tdap vaccination during pregnancy is so important. The classic childhood diseases, measles, rubella, and varicella, are covered by maternal antibodies if the mother has immunity, whether from natural infection or vaccination. Haemophilus influenzae type B protection also transfers effectively, providing early protection until infant vaccination series begins. However, passive immunity has significant gaps. E. coli K1, a major cause of neonatal meningitis, and Listeria monocytogenes are not effectively covered by maternal antibodies. This explains why these organisms cause such devastating disease in newborns despite maternal antibody transfer. This passive protection is temporary, typically waning by 4 to 6 months of age, which is precisely when infant vaccination schedules are designed to take over and stimulate active immunity development. The complement system functions as a critical component of innate immunity, working like a cascade of molecular weapons that mark bacteria for destruction, punch holes in bacterial membranes, and amplify inflammatory responses. Unfortunately, neonates operate with this system running at only half capacity. Neonatal complement levels reach approximately 50% of adult values, creating a significant gap in bacterial defense mechanisms. This deficiency affects all the essential complement functions. Opsonization becomes less efficient, meaning bacteria aren't marked as effectively for destruction by phagocytes. Direct bacterial lysis, where complement proteins create membrane attack complexes that literally puncture bacterial cell walls, occurs at reduced rates. 3 distinct pathways can activate the complement cascade, and neonates show deficiencies in all 3 systems. The classic pathway relies on antibody-antigen complexes to trigger complement activation. Since neonates have limited antibodies, this pathway functions poorly from the start. The alternative pathway should provide backup by activating directly when complement proteins encounter bacterial surfaces, bypassing the need for antibodies. However, neonatal complement proteins in this pathway also show reduced function, eliminating this potential workaround. The lectin pathway activates when mannose-binding protein recognizes specific sugar patterns on bacterial surfaces. This pathway also demonstrates significant deficiencies in newborns, particularly problematic since it provides important protection against encapsulated organisms. These combined deficiencies create predictable clinical consequences. Bacterial killing becomes inefficient, allowing organisms to establish and maintain infections that would be quickly cleared in older children. Encapsulated bacteria like Streptococcus pneumoniae and Haemophilus influenzae pose particular threats because they rely heavily on complement-mediated opsonization for effective clearance. The clinical bottom line is straightforward. Reduced complement function directly translates to increased infection risk. This helps explain why neonatal sepsis can progress so rapidly and why early antibiotic intervention becomes absolutely critical in this vulnerable population. Recognizing infection in neonates requires a completely different mindset than identifying sepsis in older patients. The hallmark of neonatal infection is that signs are characteristically nonspecific, meaning they could indicate sepsis, but they could also represent many other conditions or even normal newborn variations. Temperature instability represents the most important vital sign change, but not in the way most people expect. While adults spike fevers during infections, neonates often become hypothermic instead. This is especially true for preterm infants whose immature thermoregulatory systems cannot mount effective febrile responses. A dropping temperature in a neonate should raise immediate concern for sepsis, often more so than an elevated temperature. When neonates do develop fever, it's often a late and unreliable sign. Their immature immune systems may not generate the inflammatory mediators necessary for consistent fever production, so normal temperatures never reassure us that infection isn't present. Respiratory changes provide early warning signs, but again, these are nonspecific. Apnea episodes, particularly new-onset apnea in a previously stable infant, often herald sepsis before other signs appear, but apnea also occurs with hypoglycemia, seizures, or gastroesophageal reflux. Tachypnea reflects the metabolic demands of fighting infection, while grunting indicates respiratory distress as the baby tries to maintain lung expansion. Cardiovascular compromise develops as sepsis progresses. Poor perfusion shows up as delayed capillary refill, mottled skin, or cool extremities. Tachycardia represents the heart's attempt to maintain cardiac output as vascular tone decreases and fluid shifts occur. Neurologic changes can be subtle but significant. Lethargy might present as decreased interaction or poor feeding effort. Irritability alternating with lethargy creates a concerning pattern. Poor muscle tone makes babies feel floppy during handling, but all these signs can also indicate hypoglycemia, drug withdrawal, or neurologic conditions. This non-specific nature of neonatal sepsis signs means we maintain a high index of suspicion and often evaluate for infection even when alternative explanations seem possible. Laboratory evaluation for neonatal infection requires understanding both what tests can definitively prove infection and which markers suggest infection but lack specificity. This distinction is crucial because we often must make treatment decisions before definitive results are available. Direct evidence provides the gold standard for diagnosis. Positive cultures from normally sterile sites, blood, cerebrospinal fluid, or urine definitively confirm bacterial infection. However, cultures require time to grow, often taking 24 to 72 hours for results. Even then, culture sensitivity depends on adequate sample volume and proper collection technique, both challenging in neonates. PCR testing for viruses offers rapid detection of specific viral pathogens like herpes, simplex virus, or enterovirus. These molecular techniques provide results within hours rather than days, but they're pathogen-specific. You must know what you're looking for to order the right test. Indirect markers attempt to identify infection through host responses, but all have significant limitations that make interpretation challenging. The white blood cell count seems logical. We expect elevated counts during infection. However, neonates respond differently than adults. A count less than 5,000 often indicates overwhelming infection, where the bone marrow cannot keep pace with demand. Counts greater than 30,000 suggest active infection, but this threshold misses many cases of early sepsis. The immature to total neutrophil ratio reflects bone marrow stress. Values greater than 0.2 indicate the marrow is releasing immature forms to meet demand, suggesting infection. However, this ratio can also elevate with maternal fever during labor or other non-infectious stresses. The absolute neutrophil count provides another perspective. Values less than 1,500 indicate neutropenia, while counts below 500 suggest severe immune compromise. However, normal counts don't exclude infection, especially early in the disease process. Thrombocytopenia, with platelet counts below 100,000, often accompanies neonatal sepsis as infection, triggers consumption and decreased production. Again, though, multiple non-infectious causes can produce similar findings. The critical point is that none of these indirect markers alone provides sufficient sensitivity or specificity for reliable diagnosis. C-reactive protein represents one of our most useful laboratory markers for tracking neonatal infection, though understanding its kinetics is essential for proper interpretation. CRP functions as an acute phase reactant, produced by the liver in response to inflammatory cytokines released during infection. Think of it as the liver's way of signaling that something significant is happening systemically. The more inflammation present, the more CRP gets manufactured and released into the bloodstream. The timing of CRP elevation follows a predictable pattern that influences how we use this test clinically. CRP begins rising 6 to 12 hours after infection onset, which means early in sepsis, levels may still be normal. This delay explains why a normal CRP in the first few hours of illness doesn't rule out infection. The inflammatory cascade simply hasn't had time to stimulate hepatic production yet. CRP peaks at 24 to 48 hours, reaching maximum levels when the inflammatory response is fully established. This timing makes CRP particularly useful for monitoring disease progression rather than initial diagnosis. The half-life of 19 hours means levels decline relatively quickly once infection is controlled, making it a good marker for treatment response. This kinetic profile explains why serial CRP values provide much more clinical information than single measurements. A rising CRP trend suggests ongoing or worsening infection, while declining levels indicate effective treatment. Normal values are generally less than 10 milligrams per liter, but the trend matters more than absolute numbers. The clinical utility of CRP lies primarily in monitoring treatment effectiveness rather than making initial diagnostic decisions. When we start antibiotics for suspected sepsis, serial CRP measurements help determine whether our therapy is working. Persistently elevated or rising levels might prompt us to broaden antibiotic coverage or search for other infection sources. However, CRP lacks the sensitivity and specificity needed for reliable sepsis diagnosis in neonates, which is why we never rely on it alone for clinical decision-making. Procalcitonin offers a promising advance in sepsis biomarkers, functioning as the precursor molecule to calcitonin hormone. Understanding its characteristics helps explain why many centers are incorporating it into their sepsis evaluation protocols. The major advantage procalcitonin holds over C-reactive protein lies in its rapid kinetics. While CRP takes 6 to 12 hours to rise after infection onset, procalcitonin begins increasing within 2 to 4 hours. This faster response time potentially allows earlier identification of bacterial infection, which could translate to earlier appropriate antibiotic therapy. More importantly, procalcitonin demonstrates greater specificity for bacterial infections compared to other inflammatory markers. While CRP rises with any significant inflammation, whether from infection, surgery, or other tissue injury, Procalcitonin elevates more selectively in response to bacterial endotoxins and inflammatory mediators specific to bacterial invasion. This specificity means fewer false positives from non-infectious causes. The reduced interference from other inflammatory processes makes procalcitonin particularly valuable in complex clinical scenarios. A neonate recovering from surgery, experiencing feeding intolerance, or dealing with other inflammatory conditions might have elevated CRP from multiple sources. Procalcitonin is less likely to be affected by these confounding factors. However, significant limitations restrict its clinical utility. The most problematic issue for neonatal care is the physiologic rise that occurs in all healthy newborns during the first 48 hours of life. This normal elevation makes procalcitonin interpretation extremely challenging in early-onset sepsis evaluation, precisely when we need biomarkers most. Cost represents another barrier. Procalcitonin testing is significantly more expensive than traditional markers like CRP or white blood cell counts. Many institutions limit its use to specific clinical scenarios rather than routine sepsis evaluation. Availability remains inconsistent across hospitals, with many centers lacking the laboratory capability to provide timely results. Age-dependent cutoff values add another layer of complexity, requiring clinicians to interpret results differently based on gestational age and postnatal age, making standardized protocols more difficult to implement. Neonatal sepsis creates systemic disruptions that extend well beyond the primary infection site, producing laboratory abnormalities that often provide early clues to developing sepsis before more obvious clinical signs appear. Metabolic changes reflect the profound stress infection places on neonatal physiology. Hyperglycemia commonly develops as part of the stress response, with catecholamine release and cortisol elevation driving glucose production while simultaneously creating insulin resistance. However, hypoglycemia can occur just as frequently, particularly in preterm infants whose glycogen stores are limited and glucose production capacity is immature. The swing between these extremes often signals significant physiologic stress. Metabolic acidosis develops as tissue perfusion becomes compromised and cellular metabolism shifts toward anaerobic pathways. Elevated lactate levels accompany this process, reflecting inadequate oxygen delivery to tissues. These changes can occur before obvious signs of circulatory compromise become apparent, making them valuable early markers of sepsis progression. Hematologic abnormalities provide additional diagnostic clues, with thrombocytopenia being particularly significant. Platelet consumption increases during infection through multiple mechanisms: direct bacterial effects, immune-mediated destruction, and consumption during inflammatory processes. Fungal infections characteristically produce severe thrombocytopenia, often more pronounced than bacterial infections, which can help guide empirical antifungal therapy decisions. Disseminated intravascular coagulation represents the extreme end of sepsis-induced coagulopathy. As infection triggers widespread activation of the clotting cascade, both clotting factors and platelets become consumed, leading to simultaneous bleeding and clotting complications. DIC typically indicates severe, advanced sepsis with significant mortality risk. The critical clinical principle is considering infection whenever unexplained laboratory changes occur in neonates. A previously stable infant who develops new-onset hyperglycemia, unexplained acidosis, or dropping platelet counts should prompt sepsis evaluation even in the absence of obvious clinical signs. These laboratory changes often precede clinical deterioration, providing a window for early intervention that can significantly improve outcomes. Maternal risk factors create the foundation for understanding early-onset neonatal sepsis, with specific factors dramatically increasing transmission probability from mother to baby. Group B, Streptococcus status, represents the single most important maternal risk factor. Maternal GBS colonization occurs in 20 to 25% of pregnant women, typically asymptomatically. When mothers carry GBS in their genital tract, babies face significant exposure during delivery. This is why universal screening at 35 to 37 weeks gestation became standard practice, followed by intrapartum antibiotic prophylaxis for colonized mothers. Other maternal infections compound this risk. Sexually transmitted diseases like chlamydia and gonorrhea create additional pathogen exposure during delivery. Urinary tract infections, particularly if untreated, can ascend to cause chorioamnionitis or indicate systemic bacterial presence that increases overall infection risk. Chorioamnionitis represents established intraamniotic infection where bacteria have already breached normal barriers. Maternal fever, uterine tenderness, and foul-smelling amniotic fluid signal that the baby is literally bathing in infected fluid, creating extremely high sepsis risk. Obstetric factors reflect the mechanical aspects of infection transmission. Prolonged rupture of membranes beyond 18 hours eliminates the protective barrier that normally prevents bacterial ascent from the vagina into the uterine cavity. Each hour beyond this threshold increases infection risk exponentially. Maternal fever above 100.4 degrees Fahrenheit during labor indicates possible chorioamnionitis, even without other obvious signs. This fever often represents the first detectable sign that intraamniotic infection has developed. Labor duration creates opposing risks. Prolonged labor increases pathogen exposure time and provides more opportunities for bacteria to ascend. Conversely, precipitous labor may not allow adequate time for effective antibiotic prophylaxis in GBS-positive mothers. A history of previous infant with invasive GBS disease indicates mothers who may have particularly virulent GBS strains or host factors that facilitate transmission, creating higher risk for subsequent pregnancies, requiring enhanced monitoring and prevention strategies. Prenatal infection screening follows a carefully orchestrated timeline designed to identify infections that pose significant risks to both mother and baby, with timing based on disease transmission patterns and intervention opportunities. The initial prenatal visit, typically occurring between 8 and 12 weeks gestation, establishes baseline infection status for several critical pathogens. HIV testing uses opt-out consent, meaning all pregnant women are tested unless they specifically decline. This approach recognizes that early identification allows for antiretroviral therapy that dramatically reduces mother-to-child transmission rates. Hepatitis B surface antigen testing identifies chronic carriers who can transmit infection to their babies during delivery. Positive mothers require their infants to receive both hepatitis B vaccine and hepatitis B immune globulin immediately after birth to prevent chronic infection development. Syphilis screening using rapid plasma reagin or VDRL tests catches this increasingly common infection that can cause devastating congenital effects. Early identification allows for penicillin treatment that prevents fetal transmission when administered before the 3rd trimester. Rubella immunity testing ensures maternal protection exists. While congenital rubella syndrome is now rare due to vaccination programs, non-immune mothers need vaccination after delivery to protect future pregnancies. Mid-pregnancy screening at 24 to 28 weeks repeats syphilis and HIV testing for high-risk patients, recognizing that new infections can occur throughout pregnancy. The critical late pregnancy screening occurs at 35 to 37 weeks with Group B Streptococcus rectovaginal culture. This timing is absolutely essential for boards. GBS cultures performed too early lose predictive value for delivery colonization status. The 5-week validity window means cultures performed before 35 weeks cannot reliably predict GBS status at delivery. Notably absent from routine screening are cytomegalovirus, toxoplasmosis, and parvovirus testing. While these infections can cause congenital disease, routine screening is not recommended because treatment options are limited, and most infections are asymptomatic, making targeted testing based on clinical suspicion more appropriate than universal screening. Group B Streptococcus screening represents one of the most critical interventions in preventing early-onset neonatal sepsis, with specific protocols that must be followed precisely to ensure effectiveness. Universal screening occurs between 35 and 37 weeks gestation for a crucial reason. This timing ensures the culture results remain valid through delivery. The 5-week validity window means cultures obtained too early lose their predictive value by the time labor begins. The rectovaginal culture technique requires sampling both anatomical sites to maximize detection sensitivity. The clinician uses a single swab to collect specimens from the vaginal introitus first, then advances the same swab through the anal sphincter to sample the rectal area. This dual-site approach is essential because GBS colonization can occur at either location, and sampling only one site misses a significant percentage of carriers. The collection technique involves inserting the swab about 2 centimeters into the vagina, rotating it against the vaginal walls to collect epithelial cells and secretions, then advancing the same swab approximately 1 centimeter past the anal sphincter to sample the rectal mucosa. No speculum is required, and the procedure can be performed by the patient herself if properly instructed. 3 clinical scenarios require intrapartum antibiotic prophylaxis, regardless of culture results. Previous delivery of an infant with invasive GBS disease indicates the mother carries particularly virulent strains or has host factors that facilitate transmission. GBS bacteriuria during the current pregnancy, defined as greater than 10,000 colony-forming units per milliliter, represents heavy colonization that correlates with increased transmission risk. Unknown GBS status combined with risk factors requires treatment as well. Risk factors include preterm labor before 37 weeks, membrane rupture 18 hours or more before delivery, or intrapartum maternal fever above 100.4 degrees Fahrenheit. Documentation must be prominent in the medical record because this information directly impacts immediate newborn care decisions. Labor and delivery staff need immediate access to GBS status to implement appropriate antibiotic protocols and guide neonatal sepsis risk stratification. Intrapartum antibiotic prophylaxis represents our most effective intervention for preventing early-onset Group B streptococcus sepsis, but timing and dosing protocols are critical for achieving maximum protection. The 4-hour threshold for adequate prophylaxis is based on pharmacokinetic studies showing that this duration allows sufficient antibiotic levels to reach the amniotic fluid and provide meaningful bacterial suppression. Shorter durations offer some protection, but the 80% reduction in early-onset sepsis occurs primarily when mothers receive at least 4 hours of therapy before delivery. Penicillin G remains the first-line choice because of its excellent activity against GB and narrow spectrum that minimizes disruption of normal flora. The dosing protocol starts with a 5 million unit intravenous loading dose to rapidly achieve therapeutic levels, followed by 2.5 to 3 million units every 4 hours to maintain effective concentrations throughout labor. Ampicillin serves as an acceptable alternative with similar efficacy, though it has broader spectrum activity that may select for resistant organisms. Some institutions prefer ampicillin because it also provides coverage against other potential pathogens like E. coli. Penicillin allergy management requires careful risk assessment. For patients with low-risk allergies, typically described as mild rash or gastrointestinal upset, cefazoline provides excellent GBS coverage with minimal cross-reactivity risk. The cephalosporin structure differs enough from penicillin that serious cross-reactions are uncommon in patients without severe penicillin allergies. Severe penicillin allergies, particularly those involving anaphylaxis or severe skin reactions, require alternative agents. Clindamycin offers good GBS coverage when the organism is sensitive, but resistance rates are increasing. Vancomycin provides reliable GBS activity regardless of resistance patterns, but should be reserved for cases where clindamycin sensitivity is unknown or the organism is resistant. The clinical impact of proper intrapartum antibiotic prophylaxis is substantial. An 80% reduction in early-onset GBS disease represents one of the most successful preventive interventions in neonatal medicine. This dramatic effectiveness underscores why proper timing and dosing protocols are absolutely essential for optimal outcomes. Several neonatal characteristics significantly increase infection susceptibility, with prematurity standing out as the most powerful predictor of sepsis risk. Understanding these risk factors helps us stratify babies for appropriate monitoring and intervention. Prematurity below 37 weeks represents the strongest neonatal risk factor because multiple defense mechanisms remain immature. Preterm infants have thinner skin barriers, reduced neutrophil function, lower complement levels, and fewer maternal antibodies transferred during the 3rd trimester. The earlier the gestational age, the higher the sepsis risk. A 28-week infant faces dramatically different infection risks than a 36-week baby. Low birth weight below 2,500 grams correlates closely with prematurity, but also reflects intrauterine growth restriction that can compromise immune function regardless of gestational age. These smaller babies have limited energy reserves and reduced capacity to mount effective immune responses. Male gender consistently appears as a sepsis risk factor across multiple studies, though the mechanisms remain unclear. This increased susceptibility may relate to differences in immune system maturation or genetic factors linked to X chromosome immune regulation. African American ethnicity creates specific vulnerability to Group B streptococcus infection with 3 times higher risk compared to other ethnic groups. This disparity reflects both genetic susceptibility factors and differences in maternal GBS colonization rates and antibiotic effectiveness. Low APGAR scores below 6 at 5 minutes indicate significant perinatal stress or compromise. These babies often require extensive resuscitation, which can disrupt normal bacterial colonization patterns and require invasive procedures that breach natural barriers. Invasive procedures create direct pathways for bacterial invasion. Every central line insertion, endotracheal tube placement, or surgical procedure bypasses natural defense mechanisms, providing bacteria with direct access to normally sterile body sites. Congenital anomalies, particularly those affecting barrier function like gastroschisis or neural tube defects, eliminate normal protective mechanisms and often require surgical interventions that further increase infection risk. Formula feeding removes the protective benefit of maternal antibodies and antimicrobial factors present in breast milk, leaving babies dependent entirely on their own immature immune systems for protection.